Yes, good day. I'm Dr. Kevin Hughes. I'm a breast surgeon at the Massachusetts General Hospital. I'll be talking today about cancer prevention for more women. I had founded CRA Health, and that was recently acquired by Volpara. This is not a CME talk. I'll be talking about how CRA Health can be helpful in terms of cancer risk assessment. The topic today is the EHR and the surgeon, and it's better care coordination for women at risk of breast cancer. Basically, risk assessment and genetic testing now determine management. Patients at high risk are not treated the same as people at average risk. Women at high risk may undergo prophylactic mastectomy, now often nipple-sparing bilateral mastectomy. They may need bilateral oophorectomy. They may need chemoprevention. They may need MRI in addition to mammography, or they may need mammography at a younger age. We cannot determine what the patient needs in terms of these various risk things unless we know what their risk level is. So risk-based screening is now the new normal. Genetic testing and cancer risk assessment has fundamentally changed because now what we're looking at is the EHR having changed from adversary to an ally. In the past, the EHR often required additional work without providing additional information or clinical decision support. Today, the EHR is doing both of those things, helping the doctor or the nurse practitioner or the physician assistant take better care of their patient, or helping them understand how best to manage the risk level. We've really moved into a new era relative to genetic testing. Genetic testing for breast cancer risk really began around 1996. It was limited to only the highest risk patients, and it was done only by genetics professionals. By 2000, the thresholds for testing began to drop, so more women were eligible for testing, but the barriers to testing remained very high. By 2013, panel genetic testing began, and the barriers started to ease with more and more physicians doing genetic testing, not just genetic counselors. But the testing was still hard. It was time-consuming. It was difficult to give patient full informed consent. Oftentimes, there were a need for prior authorization for payment. It was not an easy thing to do. But today, genetic testing is easy, and it's easy because it's now being facilitated by the electronic health record. So patients have now begun to expect more of us. They expect genetic testing for them when it's appropriate. Patients are often asking for genetic testing where before they were often unaware. They want risk-based screening. They don't just want a mammogram starting at 40. They want to know what is the best way to manage their individual risk and how should they be taken care of, and should they get an MRI? Should they have additional types of tests? Should they get their ovaries removed? All of this now is expected. And they expect you to find their cancers early or to prevent their cancers. And they expect you to know their level of risk and then to adjust their screening based on that level of risk. So genetic testing is now proactive. In the past, patients developed cancer and then they got genetic testing. That was too late. The patient had missed their opportunity to prevent that cancer or find it earlier. Often we had women in their early 30s coming in with a large breast cancer when we then identified after the fact they were genetic mutation carriers in BRCA1 or BRCA2. And then knowing that, we should have done MRIs and found that cancer a year or two earlier when it was more treatable. So today, patients are finally getting genetic testing early. And because of that, cancer is being prevented or it's being found earlier. So what has changed? What's changed is that the EHR makes risk assessment and genetic testing easy. I'm going to show you the system we have today where the patient can enter her own risk information either from home or in the waiting room using a tablet PC or any other computer. So the patient can enter all of her risk factors, all of her family history, without taking up the time of the technician or taking up the time of the physician. When that data is entered, and the patient then shows up for her mammogram, the tech talks to the patient and confirms that data to make sure it's up to date and accurate. The computer automatically adds the density of the mammogram to the models and the guidelines, and with all of this information, the risk factors, density, models, guidelines, running risk calculations, the breast imager now sees all the risk factors, the model outputs, and the recommendations. That way, the imager can give the best reading possible for that individual patient. That risk information and the recommendations go automatically into the mammography report so that the primary doctor or the surgeon can see that report. And when that patient comes to see the breast surgeon, that data is already all within the electronic health record. The surgeon just uses a dot phrase to pull in the risk factors, the model outputs, the recommendations into the note. And now that note has all this information filled in without having to start from scratch. If the surgeon determines that based on this information, the patient needs an MRI, the system generates a letter of medical necessity so that it's easy to get that MRI paid for. And if the surgeon determines that the patient needs genetic testing, the genetic testing requisition form is printed out automatically, pulling in all the risk factor information to allow the doctor to get that requisition done more efficiently and more appropriately for that patient. Overall, this means higher quality care in less time. Now, what's really amazing about this is that the content is also available everywhere, not just to the surgeon and not just to the breast imager, but to all the physicians and genetic counselors taking care of that patient. Whether you're in primary care, whether you're the breast surgeon, whether you're in medical or radiation oncology, whether you're a genetic counselor or an obstetrician gynecologist, you can pull in with the dot phrase all the information about risk factors, family history, recommendations, and guidelines directly into your note without having to re-enter that data all over again. You can also add new data or add a new patient from anywhere. So if, as a genetic counselor, you find that the family history isn't quite accurate, you can fix it. When you fix it, that fix becomes available to everyone who uses this electronic health record. So this is risk assessment anywhere and everywhere, and it's without redundant data entry. So the EHR has changed risk assessment and genetic testing. We are now leaving the old world. In the old world, risk data was entered over and over again by multiple physicians. Risk assessment was done only sporadically. The data was all in the electronic health record, usually in text format, but risk assessment, the running of models, was too time-consuming and often was not done. When models were done, they were general, just for the general risk of that individual type of patient without taking into account her breast density. And breast density thus was underutilized, even though it gives specific information for the models. Genetic testing was hard. Patients who needed genetic testing were missed. Testing was mostly on cancer patients, and therefore we seldom prevented cancer because we did not know patients were carriers until after they had cancer. And cancers in young patients were advanced because they had not yet reached the threshold for screening. We knew the risk factors back then. We knew there were hereditary risk factors. We knew there were hormonal risk factors. We knew there were pathologic risk factors. We knew breast density was important. And yet putting all that together was not an easy thing to do. And again, required the same data to be entered into the computer over and over and over again. It was not uncommon for a patient to fill out a paper form and put in her family history information. The question was then, does she need genetic testing? Does she need an MRI? Does she need mammography? Does she need chemoprevention? Well, how did we figure that out? We looked at this chart and we tried to put it all together in our heads and tried to guess, and maybe we put it into a model if we had extra time. This is not an efficient process. In that old world, MRIs are usually missed. The guidelines say that about for every 1,000 mammograms you do, you should be doing about 100 to 150 breast MRIs. About 10 to 15% of patients meet that 20% lifetime risk threshold. In reality, most centers are only doing 3 or 4 per 1,000 mammograms, not nearly the number they should be doing. And genetic testing was missed. Even today, after 25 years of genetic testing, about 90% of BRCA positive patients who have not yet developed cancer remain untested and unaware they have a BRCA mutation. And for Lynch syndrome, it's worse. About 95% of unaffected patients with Lynch syndrome are unaware. This is a tremendous missed opportunity. If we were aware of who had these BRCA mutations and Lynch syndrome and now all the other mutations we can find, we could change their management, we could prevent cancer, or we could find it earlier. So the old world was where genetic testing was often done too late. Often it was done during follow-up, meaning the patient had gone years after her cancer and no one had noticed she had a mutation until sometime later when testing was finally done. A little better is when testing is done at the time of diagnosis and can help then direct care for that individual patient. But the best situation, which almost never happened, was testing the unaffected patient. Testing that patient before she had cancer and then changing her management to prevent cancer or find it at an earlier and more treatable stage. This is where we needed to be, and we have not been there because we have not had the help of the electronic health record. So now the EHR has changed risk assessment and genetic testing. We're now entering the new world. Risk data is now entered once. You don't have to have the medical oncologist enter it, and then the surgical oncologist enter it, and then the breast imager enter it, and then to have the plastic surgeon enter it. It's entered one time and available to everyone using the electronic health record. Risk assessment is automatic. The models run automatically as soon as the risk data is entered, and guidelines are looked at automatically to see who needs genetic testing. The models are density specific, so now much more specific to the individual patient. The patients needing genetic testing are now being tested. We're testing patients before they have cancer, which is when it has the most impact. We now can more often prevent cancer by doing prophylactic oophorectomy specifically and other types of surgery. And cancers in young patients can now be found early. We know these patients are mutation carriers when they're in their 20s or 30s, and therefore we can identify and change the way we manage them to find that cancer earlier or prevent it altogether. So where does this get us? When you use the NCCN guidelines for genetic testing, you'll find that over 40% of your patients who have breast cancer are eligible for genetic testing. And for those without breast cancer, it's about 16%. Now, as our thresholds change, as our thresholds become more liberal, we're going to find that more and more patients become eligible for testing. But this was the numbers based on the NCCN guidelines just a couple of years ago, a huge number of individuals who need testing. We also very often use models, and one of my favorite quotes is from George Box, who said that all models are wrong, but some are useful. Everyone in this audience has looked at a risk model at one point or another and said, that makes no sense whatsoever. The risk models are nothing but a quantitative approximation of reality. They are not reality, but they can be useful. So while the models are not perfect, we can use them to identify the level of risk and identify who needs genetic testing or identify who needs an MRI. And now models are more patient-specific with breast density. So when we look at breast density, we have to realize that breast density is a function of age. For those patients who do not take hormones, as age increases, the density goes down. For those on hormone replacement, and that's relatively few women nowadays, but those who do take it, their breast density stays relatively high over time. But as you can see, age and breast density are correlated. With the older the age, the less the density. By the same token, density is a function of BMI. The less the BMI, the higher the density. The greater the BMI, the less the density. Now, why does this happen? This has to do with at least the way I look at this as an approximation again, is that everyone has the same amount of real breast tissue, ductal lobular tissue. Of course, that's not true, but it's close to at least to help you think about it. If you put that amount of ductal tissue in a small envelope, it looks very dense. If you put that same amount of tissue in a large envelope, it does not look very dense. So therefore, the larger the envelope, the greater the BMI, the lower the density, again, on average. Now, Tyrer-Cuzick 8 took this information into account and came up with what they call the density residual. So what Tyrer-Cuzick does is to say, here's a woman of a certain age and a certain BMI. This is the density I would predict based on that density and that BMI. But when I do the mammogram, this is a density that's actually measured. So there's a difference between what's measured and what's predicted. So what Tyrer-Cuzick did was said that here is the actual density. How much greater or less is that than the predicted density? That gives you the residual density, and the risk is proportional to that residual density. So it's not just dense is bad and not dense is good. It's denser than expected is higher risk, and less dense than expected is lower risk. And this is just shown graphically here. Here is the predicted level of density for that patient. If she's at that predicted level of density, her risk is average for that relative to density. If her breast is much denser than predicted, then she is at much higher risk. But if her density is much lower than predicted, then she is at lower risk. So it's not just the absolute density, but what's the density residual compared to the predicted density. Now, using Tyrer-Cuzick 7, this was pre-density, you get a general idea of where people sit. And what you find is that the risk of cancer in a lifetime goes down over time. The older you are, the lower your risk. So what happens here is that in the 40 to 44-year-old age range, about 18 to 19% of patients are eligible for MRI who are not Jewish, about 27% if Jewish. And the number eligible for MRI drops each segment. As the patient gets older, the number of patients eligible for MRI is going to go down. This was actually why the guidelines were written this way. The people who wrote the guidelines knew that patients who were older had higher short-term risk, but they also knew that people who were older had lower lifetime risk. By using lifetime risk instead of short-term risk, they skewed the patients eligible for MRI to those who were younger, who by definition had denser breasts. This was why they did it this way. Whether we agree with it or not is secondary. But what we know here is that the younger you are, the higher your lifetime risk, the more likely you'll be eligible for an MRI. So in this new world, again, risk data is entered only once. None of us likes to enter the same data over and over again. And when you enter the same data over and over again, there's more likely to be an error at one point or another. Why not enter the data once, review it at multiple different sites, correct it as you make corrections, and make those corrections available to everyone else automatically. Risk assessment has to be automatic. Most of us do not have time to type all this data into a model every time we see a patient. If it's done automatically, we have the numbers automatically without additional work or time commitment. The models need to be density specific, and that's where Tyrer-Cuzick 8 has now become very useful. Not just what's the risk in general, but how does that particular patient and her breast density modify that risk. Genetic testing is critical, and it needs to be easy. We have to make it easy for the doctor, easy for the nurse practitioner, easy for the genetic counselor to get that test done. And that is partly in terms of putting all the information needed for genetic testing into a test requisition automatically. When you do that, patients who need testing will be tested, they'll be identified, and testing is easy, so let's get the testing done. Because we're identifying patients before they have cancer, we can test them before they have cancer. That way we can prevent cancer, or, especially in young patients, find that cancer early. So this new world is really the way to make cancer care better. And what I'm proposing is that it not only makes cancer care better, but it also makes it easier and faster and more efficient. So let's walk through how this works. The patient, again at home, enters her data, or in the waiting room enters her data, puts in her hereditary factors and hormonal factors, identifies her family history, puts in the information appropriate to that patient in terms of what her risk factors are. After she's done that, the radiology technologist looks at that data and confirms its accuracy. Once the accuracy is confirmed, the models with density included are run automatically, and we know the risk level by the various models, and we know whether the patient meets the NCCN guidelines for genetic testing. So all of this being done automatically without additional workload, without redundant data entry. At this point, the breast imager can see not just the family history and risk factors, but also the model output, the guidelines, and the recommendations. So here, all the information is presented to the radiologist, and it tells you right in bold yellow at the top, this patient's at elevated risk for hereditary cancer, and consider genetic testing. So this is a critical thing for the radiologist to have this information while they're reading the film, and then use this information to better manage that patient. That information can easily be incorporated then into a mammography report. This can be added in automatically. So you can add to the report not just what is coming out of the physician's reading of the films, but also the risk assessment. And in this case, the patient's tyroacoustic score is 25%, and therefore this patient is eligible for an MRI. And for genetic testing, she meets the NCCN guidelines, and therefore we recommend genetic testing for that individual. So this information is incorporated into the mammography report and is then available to any physician, nurse, or genetic counselor taking care of that patient. And they can be sure that these things are done at the point of care, or even the radiologist could potentially start to get these tests rolling before even sending the patient off to see the surgeon or their primary doctor. Now, the beauty of this system is that it makes life easier for the surgeon. All the information has already been put into the electronic health record in breast imaging, either by the patient or by the technologist. In addition, it's been corrected and the risk models have been run. So with simple Dot.Phrases, the physician can bring in family history, risk factors, models, guidelines, and recommendations, and all of this can be part of your note in the electronic health record automatically without having to retype all that data or dictate all that data. And having the recommendations right in front of you, having the risk scores right in front of you, allows you to give better care to that individual patient. Now, you've looked at all this information, you've talked to the patient, you've made edits if there any are necessary, and when you rerun the models, perhaps if you've made major edits, you find again this patient is eligible for genetic testing, you can go ahead and order that test with very little extra effort. A click of the button takes all the information about that individual, puts into a test requisition form, including the reason why the patient meets the NCCN guidelines, and that requisition is now ready to be added to the test, to the saliva test or blood test, whatever you happen to use, and that test can be done with very little additional manual labor. And if you identify the patient needs an MRI, the system can automatically generate a letter of medical necessity that will allow that MRI to be more likely to be approved without your having to take phone calls or do additional work. So this really is the future. Having that content available everywhere, letting every provider use a Dot.Phrase to bring that data into their note, letting every provider add new patients or new data anywhere they have to be seeing the patient. That risk assessment can be done anywhere and everywhere, and it's without redundant data entry. This is what computers are supposed to do, and now the electronic health record can help you to do this. It can help you take care of your patients better with minimal re-entry of data. So again, putting this all together, The patient enters her data herself. The technologist confirms the data and edits as appropriate. Models are run, including breast density being part of those models, and guidelines are looked at. The radiologist identifies this information about risk factors and about risk and about guidelines and what is recommended for that individual patient, and puts that information automatically into their report. The patient is referred to a surgeon as appropriate, and the surgeon can, again, using a dot phrase, pull all that information into their note without having to do that work from scratch. The surgeon now has the ability to generate a letter of medical necessity or generate a test requisition, which increases the number of patients who get genetic testing, increases the number of patients who get MRI, reduces the number of times you have to take calls for prior authorization, and makes your life easier. Overall, this is higher quality care in less time. It's using computers to make your work more efficient, the way it happens in almost every other industry other than healthcare. So I'll close by saying the future is now. I want to say welcome to the genetics EHR. The EHR is now your partner, helping you to take better care of your patients and to monitor them more appropriately. And I hope this all works well for you as it has for me. My email is here, and I'm happy to answer any questions or talk to you further as you try this out. Thank you very much.